We do a lot of services from here. Quite a lot of them are provided by other pharmacies. We tend to do them in perhaps at a larger scale. And there's regular occasions happen here, and people come, particularly after hours, with conditions where it's pretty obvious what's required. And we're not able to supply that because it's a pharmacy-only medicine. What happens now is that person has to refer it to a doctor, and then they will get the prescription, come back, and then we will dispense it. We'd like to see this shortcutted so that we're able to do the prescribing of things for relatively simple conditions.
I think it's partly about obviously individual patient choice. Some might be more comfortable using a pharmacy. In terms of access, it's convenient. We're open extended hours here till 10 every day, 8 o'clock on a Sunday, bank holidays, in fact every day of the year. So maybe for students or people who work, it's more acceptable for them to come in kind of times we're open in an evening and access those services where traditionally they might not been able to access them or take a day off work and so on. Right. So we're testing for a bacteria called H. pylori that might be present in your stomach. Pharmacists, 5 years training, 4 years at university, a year in practice before they qualify. So really the only healthcare professional on the high street, if you like, qualified in the use of medicines. So we are the expert in medicines, we are qualified to do this, and it's more appropriate that we're kind of doing some of these things than maybe other healthcare providers, allowing them to concentrate on what they do best as well. So yeah, really effective use of resources, we think.
I think there's a big shift that's coming from hospital-based care into primary care. So there's plenty of stuff that only hospitals can do, but there's part of stuff that we could do that's currently being delivered in hospitals. If you've had a hip replacement done, about 6 weeks later you'll be wanting to be seen again at the hospital in order they can follow up and see that things are okay, which sounds great, but what it often involves is that you'll spend about an hour trying to park your car, you spend about an hour and a half waiting to see the doctor. You then see a doctor who's probably not operated on you, is about 3 years qualified, and he wants to be learning his skills off his boss anyway, and he'll say, "How's your hip, love?" and you'll go, it's fine, and he'll say, "Right, you're discharged." And then the health service pays about £100 for that. Now, I can deliver that in practice. I can deliver it in a way that's just as safe, it's more convenient for patients, and will save the health service some money. The problem is I can't quite deliver it because I need a bit of extra training, I need a bit of extra help. And what I need to do is to get to a position where we can develop that extra training and develop that extra help in order that it can be delivered in practice. I think if we can do that, I think we'll save the health service a lot of money. I think we'll save the patients a lot of inconvenience. I think we'll free up hospitals to do what they're really good at, which is doing the operations, which I can't remotely do. I never would be able to do. But we can deliver stuff so it's more convenient for patients and basically safer and better. The shift from secondary to primary care, the shift from hospital services to community services is coming. Let's make it happen in a way that works for doctors, works for patients, saves the health service some money, and frankly produces a decent quality service.
The emergency care practitioner role was developed to change emergency healthcare practice in Sheffield. It was really the driving force for the change was increased emergency admissions and attendance at Northern General Hospital and the Royal Hallamshire Hospital in Sheffield. And we looked at different ways of working to take healthcare to patients who don't necessarily need to go to accident and emergency departments. Right. So this orange box here is the kit we'd carry as a practitioner to deliver wound care, which previously would only be given really at the hospital. So we started looking at training and educating paramedics and nurses in a different way to be able to take a new skill set to patients. We're seeing around about 1,000 patients a month with the relatively few emergency care practitioners that we have working in Sheffield, and we're keeping between 60 and 70% of those patients out of hospital and avoiding roughly 200 elderly emergency admissions onto a ward per month.
Sheffield's always had an eye casualty from about 1960s, when Sheffield was a city of steel, and patients used to come with corneal foreign bodies, molten metal in the eye, or welding flashes. And patients have come through for many years, and nurses have built up an expertise over those years. And it'll just be a very, very bright light. that's all that will happen. And the new service that we're doing now is for the nurses to solely see and treat the patients. So it's very much a nurse-led eye casualty. There are a lot of experienced nurses, and really it's just taking that little bit further. But it's also recognising that we're not doctors, we are still nurses, and recognising that end point where we need to hand them over if they need to be handed over. We've had the knowledge for a long time, and now we've unlocked it, and now we're helping the patients, producing a much better service for the patients of Sheffield.